Welcome, everyone. My name is Herman Chique Alfonso, and I'm the Education Coordinator for the Dementia Society of Ottawa and Renfrew County. Thank you for joining to our webinar today. We have a special topic, and it's about MCI, also known as Mild Cognitive Impairment. So we have a special speaker. Mild Cognitive Impairment, what you should know from diagnosis to the latest research. And we're very lucky to have as a keynote speaker today, Dr. Neil Thomas. So he's a neurologist, also an investigator at Bruyère Health Memory Clinic. So without further ado, I will turn over to Neil and welcome Neil to this webinar on MCI.
All right. Thank you, Herman, and thank you for inviting me to present. Hi, everybody. I'm going to be going through some information on mild cognitive impairment, as well as some research happening at Bruyère Health, and hopefully give you some tips on how to keep your brain healthy as well as we talk. So when we look at what we'll be going over today, we'll talk a little bit about cognitive impairment and what is mild cognitive impairment. How do we diagnose it currently, and what are some of the new methods that we'll be able to use in the clinic, hopefully in the future, with new biomarkers and what we're doing right now, and then a bit of update on treatments and research. So as we get older, I'll first kind of explain about the difference between what's cognitive impairment and normal aging. As we get older, we have certain parts of our cognition or thinking that will change over time, and others will decline slightly, and others should stay fairly stable. So crystallized intelligence, that's sort of your facts, your fund, your wealth of knowledge. You know, when we say we should look at the knowledge of our elders, that's what sort of accumulates over time. Fluid intelligence, though, does change, and unfortunately over time does start to decline, and that's more, how quickly you can think through things, multitasking and things like that. So, those song lyrics and movie quotes, they'll continue accumulating all through your life, even if you don't find they're as useful or need them for your day-to-day life. They're going to be stuck in there. What are different cognitive domains? So when we look at what the brain does, we generally break things down into these different aspects of memory and thinking. So memory would be our short and long-term recall, our autobiographical memory. So that's a memory of what we've done in our life. And then facts, things we learn over time. Executive function would be cognitive or complex tasks, decision-making, judgment, all of these very, complex things that we do as humans. Visual spatial task function is more around our sense of direction. It's the part of the brain that allows you to look at those directions for IKEA furniture and put it all together. Attention would be looking at our concentration and focus, and we need to be able to pay attention to things to be able to remember them and think about them later, and also get things done. Language consists of understanding or speech, reading, and writing, and then personality is sort of our behavioral traits, and that stays with us through life. When we look at what's expected to change as we get older versus what should remain fairly stable. So when we look at memory, we think of our spontaneous retrieval. So just being able to pull something out of your head, a fact or a memory, without a clue or cue can be a bit harder. So that's like trying to think, well, I need these 4 things at the grocery store. I'm going to go out and get it without a list. That would be harder as we get older. But things like knowing when you're given a clue, that's why lists and reminders can help. Those shouldn't go away. And so, if you've given yourself some tips of what you need to do, that will be helpful. Our source memory. So, where did we learn that information? You might not remember. You might remember you heard something in the news, about Canada-U.S. relations. That's obviously very attention-getting now. But you might not remember. Did I see it in the paper, or did I read it on television? Saw it on social media? But the order of events, did I go to my friend's birthday party last week and on my vacation 2 weeks ago? Those things you should still remember later on. Perspective memory, again, that's where using notes and reminders helps as we get older, because remembering something just on your own may be a bit harder. But things like procedural memory, so learning to ride a bike, we should never lose that. I don't think we will become completely obsolete, but there are probably less facts that we stick in our mind now because we jump to technology quickly. So again, I talked about the cognitive domains. We talked about what changes with memory, things like attention, so complex multitasking, being able to ignore relevant distractions. So maybe, as a teenager or in your 20s, you could do study and have music on and have lots of people running around in the house and still be able to take things in, but as you get older, that gets harder. Language, you might have everybody notices that tip of the tongue phenomenon, might search for words a little bit, but your vocabulary should stay pretty steady through life. Visual spatial functions, so our constructional ability, so that IKEA furniture might take a little longer to put together after we're retired compared to when we're younger, but simple tasks and recognition of objects and people and navigation should stay fairly much the same. Executive function, again, how quickly we can put something together, how quickly we can do a complex task, it becomes a bit more difficult. Problem solving is a little bit harder, and how quickly we do things, our processing speed declines. But our behavior or personality, how we act, that should remain fairly stable. So for the topic of today, when we look at normal aging versus cognitive impairment and what mild cognitive impairment is, there's sort of a continuum of changes when people are developing memory problems that are not expected for aging. So we talked about some of the things that we expect as you get older, small changes in memory, but you should obviously still remain independent for your day-to-day life. Mild cognitive impairment represents part of a change which is not normal aging. So this is when there's memory problems that are more than we'd expect for the normal aging process. So not those tip of the tongue moments, not needing a list for groceries, starting to forget things on a more regular basis. And it shouldn't have, at this stage, a major impact on your day-to-day independence and what you can do. You may be slower, but you're still independent for your daily activities. And whereas when we see dementia, that we still see significant changes in memory and thinking, but now you're starting to require assistance in your daily activities. And so that's one of the ways to differentiate that. So what do we mean by daily functioning? What are instrumental activities of daily living? I'll bring that up because it'll be referred to a little bit later on as well. So these are the more complex things that we do. Basic activities of daily living are things like dressing, bathing, personal care. Instrumental activities of daily living are the more complex things. So managing your schedule, doing banking, finances, putting your taxes together, shopping, managing medications, doing things like laundry and housekeeping, and using electronics. So again, now to go to the formal diagnosis of what is mild cognitive impairment, they're cognitive changes that represent or cognitive concerns that represent a change in cognition or memory and thinking that is either noticed by the person or an informant. And that's important because with some of these changes and some of the diseases that cause mild cognitive impairment, people might not even notice a difference. It might be a family member or a friend who is suggesting they get their memory tested. And we need to see that, either historically from information from the person or their friends or observed with evidence, being seen in the clinic multiple times, that there's a change over time. The objective, meaning evidence that we get of impairment from tests, needs to show deficits or problems in at least one of those 6 cognitive domains that I mentioned, and usually it includes memory, but not always. And this is where, again, we determine this with cognitive tests and memory tests, things like the Montreal Cognitive Assessment. But there should be, again, preservation and independence in your day-to-day functional abilities. So you should still be able to do all these independent things, although, again, it might take a bit longer, it might be a bit slower, you might need more planning, but you're still able to do it on your own if it's considered mild cognitive impairment. Are there different types of mild cognitive impairment? So yes, when we look at how we classify mild cognitive impairment, we look to say, first off, so that we have cognitive changes that are not normal for age, the person's still independent, but there is decline over time. Is their memory impaired? Yes. Then we consider that amnestic mild cognitive impairment. And so that's when memory is the most notable change. And then, but it can affect more than one thing. So it can affect just memory, and we consider that single domain amnestic mild cognitive impairment. So only memory affected. Or there could be problems with memory as well as language or visual spatial function, and that would be considered amnestic multiple domain. Or people's memory may not be affected. Certain types of dementia don't affect memory as much earlier on, and cognitive impairment. So we could have non-amnestic mild cognitive impairment. And again, we look to say, is it a single thing that's affected? Maybe it's only a language problem to begin with, or are there multiple domains? And doesn't matter. So why do we have this classification? Well, it helps us, to determine maybe what's the underlying cause. So amnestic mild cognitive impairment, either single or multiple domain, is more likely to represent possible underlying Alzheimer's changes. So this might be early changes before someone develops dementia. Whereas non-amnestic might point to a different type of dementia or a different cause. And then the other importance here is if someone has multiple domains affected versus a single domain, that does unfortunately mean they're more likely to get worse over time. Their mild cognitive impairment is more likely to progress. So how common is this? What are we expecting when we think about mild cognitive impairment? So it's estimated from research studies that around 12 to 18% of adults over the age of 60 have mild cognitive impairment. Like dementia, mild cognitive impairment increases with age. So that, the older you are, the more likely there may be cognitive deficits. And age is one of the bigger risk factors when we look at cognitive impairment and dementia. What are the causes? MCI, mild cognitive impairment, is just a general term. As I mentioned before, it just means problems with memory and thinking that are more than we'd expect for the normal aging process, with fairly preserved independence in your day-to-day activities. So it can be caused by many different things. We've just now said that's a general term, but it doesn't tell us what's actually happening in the brain. And so we use our clinical diagnosis to try to find out what's going on based on the information that we get and the type of problems that the person's experiencing. Unfortunately, when we look at mild cognitive impairment, the most common the most common thing that's happening in the brain that's causing this cognitive impairment is a neurodegenerative disease. So that means diseases that are affecting the brain where the brain is deteriorating over time. We're losing brain cells because of these diseases. So that's things like Alzheimer's disease, Parkinson's disease, dementia, or Lewy body dementia, frontotemporal dementia. But those aren't the only things that cause mild cognitive impairment. It can also happen after a stroke. So if we look at cerebrovascular disease, so blood vessel disease in the brain, that can be affected after someone's cognition or memory can be affected after a stroke. There's also what we call microvascular or small blood vessel disease. So the small blood vessels over time, just like any other organ in our body, they age and there can be problems like hardening of the arteries. And then when the blood flow is not as good in those tiny, tiny arteries in the brain, that can affect how well the brain is functioning and how much energy and nutrients and oxygen it's getting. And we have small blood vessel disease that can affect memory and thinking and cause a vascular cognitive impairment. There's other medical conditions that can cause cognitive issues. So things like alcohol abuse, thyroid disease, vitamin B12 deficiency, certain chronic diseases. Now, I want to say, not to be worried that it doesn't mean that if I've listed these here, that anybody with a little bit of changes in their kidney function over time is going to develop cognitive impairment, but people with more severe kidney or liver disease can have impacts on the brain. Things like sleep apnea, and then poorly controlled epilepsy, people that have multiple seizures. Certain psychiatric conditions can impact how well people are able to function day to day, but also their performance on memory tests. And so that can be a cause of mild cognitive impairment. And then medications as well. Sometimes people are on different medications or too many medications. So what happens with mild cognitive impairment? Well, most people with mild cognitive impairment, it is a risk state that things are going to get worse over time. So when we see people here, there may be a slow decline or people remain fairly stable. There more commonly can be a worsening over time. And in some people, usually again, if a disease has been, if a reversible cause has been identified, people could have mild cognitive impairment and then actually improve. That's a smaller percentage of people though. Again, why is it important to determine and detect mild cognitive impairment? Because it can be, again, that sign that things are maybe getting worse over time, and there may be problems that are developing due to an underlying disease affecting the brain. So in people who have mild cognitive impairment due to underlying Alzheimer's changes or Alzheimer's disease, that change from going from mild cognitive impairment, so fairly independent, to dementia happens in about 10 to 15% of people per year. And then if we look at people who don't have a diagnosis of mild cognitive impairment, that happens much less frequently, so maybe only 1% per year. And as I mentioned, there's a higher risk with multi-domain mild cognitive impairment. And again, just to finalize, so we're sure what's the difference. The difference here when we look at the diagnosis of dementia versus mild cognitive impairment is dementia means there's now the interference with the ability to function at work or at usual activities that represents a decline from previous functioning. And then again, we're getting the history of cognitive impairment in a similar way, where we're getting cognitive information from the person who has the problem, but we also want to get an informant, a family member, a friend, or a spouse, because that person may not realize there's a problem. And ways to determine whether there's changes in day-to-day activities are things like these checklists. So we can do functional checklists that look to say, how are people doing in terms of things like finances? It's normal, it hasn't changed, or now they require assistance. And those are standardized ways we can try to figure out changes that might be happening that tell us that people have progressed from mild cognitive impairment to dementia. So another thing that I was asked to go over with this presentation was, how do we diagnose mild cognitive impairment? So currently, it's a clinical diagnosis. We need to get information on a history. We have someone come in my role. I work at the memory clinic, and I see people there with their family, and so we try to get a history, and this is a very important part of it, to find out what's happened over time, how long has it been happening for, and all of that can give us information about what might be the cause of this mild cognitive impairment or these changes. So what pattern of changes, and is it not expected because of aging? What aspects of memory and thinking are affected? Because that can help us point to what might be the cause of the disease. Has the progression been gradual? So as I mentioned, someone could have dementia or mild cognitive impairment after a stroke. And that would be a very different presentation than Alzheimer's disease. Someone would have the stroke and they would notice, changes right after that, whereas something like Alzheimer's changes very slowly and over many months or years. And again, as I mentioned, it's always important when we're seeing someone for cognitive impairment that we get information from a spouse, family member, or friend. We want to know their family history. Again, that can point us in the direction of something that may have a genetic or a component related to a family history. Medical history, so we want to look for other conditions. So again, obviously, I want to know, did someone have a stroke in the past? Does someone have high blood pressure or diabetes or other things that might affect their medical health? Medications, I always get a good review of that to know, are there any medications that could be impacting memory and thinking? And then, knowing about their social habit and history. So smoking and alcohol use, obviously, those can have negative impacts on the brain and how physical active and things like that they are. We'll do a neurological and physical exam again to see if there's any changes on the neurological exam that point to one thing or another, past signs of a stroke, signs of Parkinson's disease, or things like that, again, to help us to determine what could be the cause of the mild cognitive impairment. We'll do cognitive testing, which is generally pen and paper tests and given in the office. So things like the Montreal Cognitive Assessment or the Mini Mental State Exam. And that gives us a kind of standard of saying, okay, how is this person doing compared to what we'd expect as normal? We do laboratory tests, as I mentioned. Other medical conditions could cause mild cognitive impairment, and we don't want to miss something that we could treat. So we're going to look at, thyroid levels, vitamin B12, liver and kidney function, and things like that. And then a CT scan. So first off, we want to make sure we're not missing something that would be treated differently. Again, did someone have a very slow-growing tumor, or has someone had a silent stroke? Sometimes we only find those after brain imaging. People don't always present with that droopy face and weakness on one side. We can see what would support the diagnosis of a neurodegenerative disease as well is shrinkage of the brain. So here we can see the brain is fairly full. but as we move along and see someone with amnestic mild cognitive impairment and now someone with Alzheimer's, we can see shrinkage of the brain, which we would consider not normal for aging. The brain does change as we age for everybody, but if there's more shrinkage than expected, this would help us to support a diagnosis of a neurodegenerative disease. So we might have a bit more information even at the mild cognitive impairment stage to say, okay, well, I think this is someone who might get worse over time. So I'm just going to put this up. This seems like a very complicated slide here, but this is just an example of why it can be hard to predict what will happen to someone after a diagnosis of mild cognitive impairment. So studies like this show us how complex mild cognitive impairment and dementia are, and that the most common change that's happening, especially in older people over the age of 75 or 80, is multiple things are happening. So here was a study that enrolled people who were over the age of 75 or 80. They then followed them for years. They did memory tests every year, and then when the participants of the study died, they did an autopsy and looked at what was happening in the brain. So this is the information from the autopsy, and these little letters here represent either Alzheimer's disease changes, AD, vascular or blood vessel changes in the brain, or other causes of dementia like Lewy body dementia or frontal temporal dementia, and the 0 here means no changes. So we can see, unfortunately, like our other organs, our brain is not as healthy when we're older, even in people who don't have mild cognitive impairment or dementia. So these are people who were deemed to have normal cognitive testing, no cognitive complaints. But on autopsy, we can see that their brain did have some changes, even if they were normal during life. So some people had Alzheimer's disease changes. Now, maybe they were more mild than people with the Alzheimer's disease itself, but there were vascular changes. So more than 75% of people had some change in the brain. People with mild cognitive impairment who were thought to be developing Alzheimer's disease also, again, mostly had, more than half had some Alzheimer's changes already, but others had vascular change. And then again, the difficulty in making these diagnoses is even the people that were diagnosed with Alzheimer's disease in life, there's a percentage of them, maybe 20% or so, who actually didn't have Alzheimer's disease, but they had multiple changes. So what this tells us is, as people get older, it's a bit more common that there are multiple changes that are happening in the brain. And that's important for us to know as doctors, as researchers, because then we need to know that, yes, it will be very beneficial if we can, find treatments for Alzheimer's disease and reverse that. But that's not going to be the only way that we slow down or stop dementia. And so again, as I mentioned, it would be wonderful. My job would be much easier, and maybe it'd be taken over by AI very quickly if people's diseases followed the textbook definition. So the idea that people think for amnestic mild cognitive impairment, which is the risk or what we think is what happens before people may develop Alzheimer's, or when we look at Alzheimer's, the thought is that people present with primarily memory problems. But as you know, if you know anybody with dementia, people with mild cognitive impairment or Alzheimer's disease can look different in every person. So although the typical form of Alzheimer's is slowly progressive changes in memory, there are some people that have more significant changes in their language. There are some people that have a visual variant, so more visual spatial change problems. And so when we first diagnose someone with mild cognitive impairment, knowing what the effects are and what's impacted, might help us to get a better idea what their progression will look like. So when we look at that clinical diagnosis, how good are we in the clinic? We're correct in about 70 to 80% of times. So like I said, even in here, about 80% of people who are diagnosed with Alzheimer's actually had Alzheimer's changes. So what do we do when I'm saying this is all a clinical diagnosis and we're not correct all the time? How do we get better at diagnosing it? What are things that will improve our ability to make a correct diagnosis? And it's even harder with mild cognitive impairment than when someone reaches a stage of dementia because there's so many more different things that could cause it and it's more subtle. So if I'm seeing someone here, are there things that we can look at or start to look at that will allow me to know, is this person going to be on this trajectory, staying fairly stable over time, or is this a person who's going to start to change and decline? And that can help if we are able to do that earlier, because we could maybe focus on, okay, maybe this person has mild cognitive impairment and we think it's due to Alzheimer's disease. So maybe, newer medications or medications for Alzheimer's disease would be indicated. But if it's more likely not to be Alzheimer's and more likely to be related to blood vessel or vascular disease, maybe we look at more, prevention strategies, lifestyle changes, and controlling those risk factors. So this is, again, just kind of showing when someone develops mild cognitive impairment, so symptoms, when they actually have these memory changes. So here, this purple is when people start to have memory changes, and the green is when people start to have problems with their day-to-day functioning. This can be years after the proteins that build up in Alzheimer's disease, which are amyloid and tau. Those have already developed years and years earlier. And when I see someone here, I have no idea what's happening in the brain here. I'm just trying to look at a clinical diagnosis, and then we follow people over years. So how do we sort of start to get information here at this earliest stage and know, what's already happened and changed in the brain? So there's different biomarkers that are being studied and, hopefully will be able to be used in the clinic. So amyloid PET scans look for those abnormal proteins, amyloid and tau, that are associated with Alzheimer's disease. And so we can see here, they essentially inject a dye into the body. You do a brain scan, and this attaches onto the abnormal forms. Everybody has amyloid and tau in their brain, but the abnormal forms are what we don't want to see. And so these markers attach onto that, and they can be seen with these types of scans. For a different disease like Parkinson's disease, there's something called a DAT scan, or dopamine transporter scan. This looks for the level of dopamine, which is decreased in people with Parkinson's disease. So that's another way to kind of get a look in the brain, what's happening during life. Another thing that we can do to look for changes related to Alzheimer's disease is do a spinal tap or a lumbar puncture. So there, we have fluid around the brain and down the spinal cord, and the spinal cord ends around here. We can stick a needle in and pull this fluid out and then do tests on that. So if we find low levels of amyloid and high levels of tau, that's consistent with what we would see in Alzheimer's changes in the brain. And that at an earlier stage of mild cognitive impairment may give us information. This is a highly accurate test, but you can imagine not many people like to have a needle poked in their back, even though it's a pretty standard procedure. So it's invasive and it's time consuming. So we're trying to look at different ways. So the PET scan, has the advantage of not being invasive, but they're fairly expensive and they need specialized centers to be done. So we can't do that anywhere in Canada, right? We're not going to have a PET scan in Northern Ontario, unfortunately. So that limits things to larger areas. So the newer things that are being looked at and tested and getting closer to being able to be used in the clinic are blood tests. So again, we want to look for those for at least in the case of Alzheimer's disease, we're looking for abnormal amyloid and tau. So these are looking at the abnormal forms of this. And actually we find if we put these two together, looking for this beta amyloid level and this phosphorylated tau level, that's actually a better marker of what might be happening. And so people might have seen, so this was a recent news release, the FDA in the US has just cleared and approved one of the first tests that will be a blood test that can be used in the clinic side, and they feel it finally has a reasonable enough accuracy. So when we look at that, what is this showing? The blood-based tests are just over 90% accurate. So they're not perfect. They're not going to find everybody with Alzheimer's disease. So unfortunately, we'll get tests where it's not positive when people actually have Alzheimer's changes. More importantly, thankfully, though, it's a smaller amount of people where we'd have a false positive test. So that's only a small percentage where someone would be test positive when they actually don't have the changes. But those are all things we have to think about with these diseases. Like we think, okay, it's great. We need to do these blood-based tests. We want to get that. But, as a clinician, I want to make sure the test that I'm doing is accurately telling me what's going on. And so it's taken a while to get the accuracy of these tests up to the level of what we see with a PET scan, and that we can trust that. So where could we move forward with this? So this was a study that looked at, they had physicians in the clinic see patients, and then they gave a prediction of, based on their assessment, their history, their cognitive testing, what did they think would happen to that person over the next 2 or 3 years. And then this study also looked at using this plasma, this phosphorylated tau, a standard memory test, a standard test of executive function, an ApoE, which is a genetic, which is a gene that increases your risk of Alzheimer's disease, whether you have one or two of those. And if these tests were done, this was actually better than the clinician's prediction. So what we hope moving forward is adding things like a blood test and maybe a genetic test to look for risk genes like ApoE, ApoE4. We could plug something in and give us a bit better idea. So this is showing, someone was 75 with a high school education. They scored low on a memory test and low on an executive function test. And they had a positive tau test and an ApoE allele, their risk of converting to dementia over the next 2 years would be 95%. And so we can maybe get better ways to tell people what might happen in the future. So then you might ask, well, if these new tests are coming out and we can look at finding biomarkers of Alzheimer's disease early, why don't we just test everybody? We'll find it way before these memory symptoms happen. So the problem with that is, first off, these tests are actually more accurate in people where we think they have a disease. So we have more risk of getting false positive or false negative tests if we are just testing people who are normal versus people who have mild cognitive impairment. So a part of when we do a test, they're more likely to get a correct positive or negative result if we're looking in people who might have the disease we're looking at. So when we do these tests in people with mild cognitive impairment, they're more accurate than just doing it in anybody. The other thing, too, is we don't know. So we know that Alzheimer's disease needs both amyloid and tau. Most of the blood markers we have right now, even though that one, the tau 217 test, it actually gives us a better indication of whether there's abnormal amyloid or not. And so some people could have abnormal amyloid in their brain and never develop Alzheimer's or dementia. So, we don't want to put people on medications when they have no signs of cognitive impairment and only amyloid in the brain if they're someone who might never develop dementia or Alzheimer's disease, when medications could have serious side effects. So, we want to get better and better at diagnosing things earlier, but we want to make sure we're accurate as well. So that's one of the reasons, again, why we're not going to suggest that everybody just gets screened with these blood tests, because if you're 40 or 50 and you might only have a few % chance of developing Alzheimer's in your life, even if you have abnormal amyloid, because maybe those other changes, like the changes to tau or those mixed pathologies that I showed, like vascular changes, those things haven't happened. And we've seen some, studies have looked at people in their 80s and 90s who have a higher level of amyloid, but never developed dementia because these other changes didn't happen. So what's available now? Where are we moving with this diagnosis in people with mild cognitive impairment and getting better at saying, we think you're someone who might have this underlying disease, you might be someone who is more likely to remain stable and it's not going to change over time. So the amyloid PET is available as part of a special registry project to some clinicians. And the point of this project is to say, can we start to use this in clinical settings and can it be helpful? Tau PET is really only available in research, and we're still working on how well that's going to be used in the clinic. Cerebrospinal fluid testing, so the lumbar punctures are available, but they're not covered by OHIP, and you obviously have to have a center who can do a lumbar puncture. The DAT scans, again, only available in research, and the blood-based biomarkers we can actually do, not this new FDA test, the tau to beta amyloid ratio, that hopefully will be coming soon, but the single amyloid and tau are available with some providers, but they're not covered in Ontario. And that's likely because we don't have treatments at this point. So moving on, where are things going with treatment of mild cognitive impairment? Right now, we have drugs approved for people with Alzheimer's dementia, but there's no medications that are currently approved in Canada or until recently that have been found to maybe benefit people at the stage of mild cognitive impairment. And so people may have heard of the new anti-amyloid medications that have been tested and shown some benefit and are currently approved in some other countries and are still being looked at by Health Canada. But then another promising area is looking at non-pharmacological treatments. So one of the medications that has shown some promise and would be different than the current medications that we have is called lecanemab. So this is an antibody that binds to beta amyloid and kind of pulls those abnormal amyloid plaques out of the brain. They had a large study here. People were followed over 18 months, and there was over 700 people in each arm of the study. So this was people receiving the drug versus receiving the placebo. This medication is given by an infusion. So again, it's not as easy as just taking a pill. People were measured using the Clinical Dementia Rating Scale, which is a test that looks at both cognition and function. So it's kind of like that pen and paper memory test, as well as that checklist that I showed you. So it looks to see how do you do on memory tests, but also how are you managing day to day? And are there changes in your cognition, or those cognitive domains, as well as functioning? So what happened is people on the medication, they declined about 35% slower than people on the placebo. Now, out of this 18-point scale, that was only about a 0.4 difference. So, how much is that noticeable in day-to-day life? That's one of the reasons why, I think it's still being looked at. So there's a benefit, and it came out as significant in the statistical analysis, but how much are people going to notice day to day? It's a great step forward. We now have a potentially disease modifying drug, but we'll have to find out with a bit more time about how much of a difference, because these pen and paper tests people don't care about as much. What you care about is how you're doing day to day. What it was very good at, this is the amyloid level in the brain. So it really brought down those amyloid plaques very well. Now, the downside, though, is, and again, the reason why it's important to look at these and see what's the real benefit we're going to see to people's day-to-day functioning, is because around somewhere between 14 to 20% of people develop some changes. So this was swelling in the brain. Thankfully, most people didn't have any symptoms. So only 3% of people who had a change due to the swelling or these tiny little microbleeds actually showed symptoms of this happening. And so most of the time, by stopping the medication or reducing the dose, these small areas of swelling in the brain would go away. But it's still something that, is a significant change and a side effect that could be concerning. And that was happening more so in people who had this ApoE. So this is, again, a gene that's a risk factor. So what most countries that have done that have approved it have said, well, this risk is 30% of people with the ApoE gene versus only 5% of people without. So some of them are limiting its use to people who have only one or no copies of the ApoE gene. Donanemab, very similar. It's an antibody that binds to beta amyloid. Again, large study. The big thing with these is instead of only testing people with Alzheimer's disease at a stage of dementia, most of the people in both of these trials were at a stage of mild cognitive impairment. And so we're seeing benefit even earlier on in mild cognitive impairment, not just dementia. This one used a different scale called the IADRS, essentially the same kind of thing, though. It was a pen and paper cognitive test with looking at functioning. And similarly, there was a change of about 30%. And again, about 3 points on this 144-point scale, but significantly different with the statistics. The donanemab also did very well at clearing out the plaques as we look on this is an amyloid PET scan showing a high level, and this is a decrease over time. Again, though, some reasonable levels, and about this is a little bit higher, 20% of people with some sort of swelling, and about 30% of people who might have these microbleeds. But we can see this happens in people with Alzheimer's as well. So it's partly due to the disease, but the drugs do change this a little bit. And again, having two ApoE alleles showed a higher rate of these symptoms. So what are some maybe non-drug treatments that we could look at that have shown evidence and benefit in research studies? So one I'll bring up is called the Healthy Action to Benefit Independence Thinking. This is a 10-day multi-component program, and I'll show you a couple of these multi-component programs, because what we're finding out is maybe if we add multiple things together, like support groups, physical activity, training, brain training, rehabilitation, we can help slow down changes as well, just like we might see with medications, maybe not as significant of an effect, but some benefit overall. So this is a 10-day program where these 5 different components are done. So there's a memory support system, there's a training program to learn to use the memory support system planner. So this is a planner, a day planner that has, schedule of events, putting together action list of what needs to be done, and then notes and journal. The point of this type of rehabilitation is it uses your procedural memory more so, like that learning to ride a bike. So you're just taught how to use this planner system over and over and over, so it becomes second nature. And it's shown that it helps with preserving independence in people with mild cognitive impairment somewhat. There's also group supportive therapy. So knowing, like we're doing today, learning a bit more about what is mild cognitive impairment, what am I going to expect, what sort of things should be done for this. Adding, mindfulness and physical therapy with yoga, brain fitness using a computerized brain training program, the Dynamic Brain or Brain HQ, and wellness education. For the important part is this is for the person with mild cognitive impairment as well as their partner. And so this helps them to get, more expectations of, employing this daily memory compensatory tool, enhancing your knowledge about mild cognitive impairment, learning about supportive strategies, increasing psychological well-being, and improving physical conditioning and balance and things like that. Was it a benefit or not? So what I'm showing here is different aspects of what was tested. So quality of life, memory-based independent daily activities, daily functioning. So again, that's that clinical dementia rating that was used in one of the drug trials that looks at cognition and functioning, and then physical as well. So the memory support system you can see in two areas for remaining independent and memory-based functioning. There was a significant benefit to it. Yoga also showed some benefit. So the dark green or the full green here are where there was an individual, a primary effect from just that intervention. And then the shaded shows when these all five were combined together, there was some benefit on these other functions from this component of it. So there's some benefit overall in quality of life, mood symptoms, remaining independent in your daily activities, and overall cognition and functioning. What about for the partners of people who are undergoing this program? Well, there was again benefit there. So things like the yoga, the cognitive rehabilitation, that memory support system planner seemed to help with mood, anxiety, and feelings of burden or burden level. So what else is being used and what else is being looked at? So there's a large trial called the FINGER trial. This is, again, a multi-domain intervention. So we want to see, if we work on these healthy lifestyle interventions and combine them together, can we show a benefit? So the initial FINGER trial was for just older adults without cognitive impairment or dementia, and they looked at different components: nutrition, exercise, cognitive training. Follow people over time, and they found benefits in cognition, lower heart risk, lower risk of declining your day-to-day functioning, lower risk of chronic disease, and better health-related quality of life. This then did a study looking at people with mild cognitive impairment, and either they went through the intervention, which was this multi-component model, and a medical food, which contained different, omega-3 fatty acids and things like that, and vitamins. And what happened compared to people who didn't get this multi-component intervention and just were sort of followed by the research team. So what these multi-component interventions, which included recommendations for an improved diet, it's a Nordic nutrition. It was a Finnish study initially. To at least 60-minute sessions of exercise per week, cognitive training with computer-based training and group sessions, increasing social activity and managing vascular risk factors. So people's dietary intake improved. There's decreased cardiovascular burden and slower decline in cognitive abilities. A very similar trial, these were actually published in the same journal at the same time because they were both showing some benefit potentially for these interventions for people with mild cognitive impairment, was another group that looked at, again, a multi-component intervention consisting of a healthier diet, so sort of a Mediterranean-style plant-based diet, exercise every day for at least 30 minutes, combining aerobic and strength training, stress management with meditation and yoga, group support, and then other supplements. And so what we're looking at here is the cognition and function score. So higher is worse, lower is better. So at the end of the intervention, 20 weeks later, the people who were in the intervention had gotten a bit better in their overall functioning and cognitive tests, and their cognitive test scores had improved as well. So they're getting better, not getting worse. So the down is better. They had improved cognition, slight improved function in daily activities. And very interestingly, they also did these blood-based tests, and they found an improvement, so a decrease in the Alzheimer's biomarkers with these healthy lifestyle interventions. So that tells us some of these things that we do, could be helping to reduce our risk of specific diseases, even things like Alzheimer's. So how do we reduce your risk of cognitive impairment overall? As I mentioned, these multi-component interventions are finding benefits, and these are general things that are good for brain health as well as people with mild cognitive impairment. So a Mediterranean style diet or a MIND diet, which is Mediterranean style and a hypertension healthy diet, increasing fruits and vegetables, increased physical activity, and treating hearing. So this was a big study that looked at these different components. So looking at each of these risk factors, so hearing loss, high cholesterol, depression, diabetes, social isolation, and they said, if we reduce this, how much would we modify or reduce the risk of dementia? And amazingly, they found that, by eliminating these risk factors, that potentially 40 to 45% of cases of dementia could be delayed or prevented. So again, these are all things that we can make changes in our day-to-day life to improve, again, in diet, physical exercise, things like that. Sleep is very important. Sleep is clearing away those toxins and things that build up during the day. So getting adequate sleep, treating sleep apnea with CPAP is important. Things like cognitive training. No clear program has shown a benefit, but there are computerized cognitive training. What I say is find, some cognitively stimulating activities that you like to do and stick with it, whether it's art or music, taking a course at community college, learning something new, or doing these kind of computerized brain games. If you love those, then great, do those. But you want to keep your brain active even after retirement, all through your life. And also you want to be careful, maybe checking with your pharmacist what medications you're on, or any even over-the-counter things can impact your memory and thinking. So hopefully that was informative on, information about mild cognitive impairment. I'll just spend a brief couple of minutes talking about research that's happening right now at the Bruyère Research Institute into mild cognitive impairment, and then I'll leave time for questions. So as I mentioned, that memory support system is part of that Mayo Clinic habit program. So we're actually looking to say, we know that this may have some benefits for people with mild cognitive impairment, and we want to know, could we implement this in a Canadian setting that's available in some institutes in the US, in a memory clinic and day hospital setting at Bruyère? Would it show similar benefits to the program of the Mayo Clinic? And we're actually currently recruiting for this study, again, individuals with mild cognitive impairment and a partner. Now, another study we're kind of building on from this memory support system with collaboration with the group at the Mayo Clinic as well and Carleton University is, the current memory support system is a paper-based calendar planner, but a lot of people are using electronic calendar systems. So they'll look and say, well, if I'm already using my Google Calendar or some other type of electronic calendar, you want me to move back to a paper calendar? Well, I'm comfortable with this. So we want to see, can we develop an electronic version, still relying on those habit memory principles? Can we, overlearn someone to do something and make it a habit, and be able to do a easy to use planner that has that same scheduling, to-do list, and notes sections? And does it work as well as the paper-based mild cognitive impairment or paper-based MSS? And to build these things, it's really important that we involve people, with the condition, get their insight. So, we will be recruiting soon. We've already done some sessions to test and get input from people with mild cognitive impairment about, how this calendar system is working. So other sort of more novel tests that we're doing is, again, moving this earlier. Like, how early can we detect when there's changes in people who are experiencing mild cognitive impairment, and not just have to wait till other people notice it and they go to the clinic and, they have the wait list before they're seen in the clinic. So even things like as simple as blink. So blink-related oscillations, which are changes in the brain, which we can pick up on EEG just by sitting in a screen and staring and blinking. They may be different in people that are not having any problems versus people with mild cognitive impairment and dementia. So this is another study that's recruiting people for mild cognitive impairment to look at early detection of cognitive impairment and trying to get at that. Does that person have mild cognitive impairment as early as possible? Driving changes with aging, and so we have a very fancy driving simulator now at Bruyère, and we want to know, first off, we have to know what's healthy for people. We've developed a standard driving test. So could we use that for two things? Could we use that to help maybe identify changes in people early on, but also could we help to, identify people who may be experiencing mild cognitive impairment but are still safe to drive? And can we do that better than we do right now in the clinic? And so we're recruiting healthy older adults, and soon, hopefully in the summer, we'll be recruiting people with mild cognitive impairment. This is another one, just again, in a new novel way that we're looking at it. That we're not recruiting for this study right now, but we started to look at, could we, instead of using a very expensive, could we use two things that change over time and may change in people with mild cognitive impairment or dementia, their language and their eye movement. So could we have someone do a simple test where they stare at a screen and describe a picture and do a few other things? We monitor their eye movements, listen to their language, and could we, make that an easy test for people to do that's more sensitive to detecting early changes in memory and thinking. And instead of using a very expensive research Tobii eye tracker, can we do it using a webcam? So that's all I have today, and I'll just leave this slide up. So if you are interested in participating in research or learning more about research, we have a website you can visit, or you can contact this number here or email us at memoryresearch@Bruyère to learn about what studies we have going on right now.
All right. So, well, thank you so much, Dr. Thomas, for that great presentation, very informative presentation. So I can see there's one question. So just invite the crowd. I see there's a large group. So if you have any question, please type your questions on the Q&A box. So I'll happy to read it for you. So the first question is, do you believe the benefit of yoga comes from the mindfulness of the physical aspect, stretching, straightening, or yoga, sorry.
Yeah, so I think it's probably a bit of both. And that's one of the reasons that the Mayo Clinic chose something like yoga. Because it's more than just the physical activity, but there is hopefully some benefit in reducing stress and this mindfulness aspect that comes to it as well. So I do think it's probably a multi benefit, and that both of those are helping. We have evidence from other studies looking at physical activity on its own. And there is very good evidence to say that, staying more physically active through your life is really beneficial for brain health. So first off, it can maybe help to prevent or delay someone developing memory problems. It keeps your brain healthier through your life longer. But also for people who are suffering from mild cognitive impairment, again, I showed before that, that risk of change, right? So the people developing Alzheimer's, they change maybe like that. People with mild cognitive impairment from maybe vascular changes, maybe they change more slowly. But we want to take that slope, that change, rate of change, and make it as slow as possible. And we can do that, we think, even in people with things like Alzheimer's, by doing some interventions like these multi-component interventions that I mentioned. So they did take that rate of change that was happening like this, and they slowed it down. And physical activity on its own seems to be something that really helps and may improve brain health. So that on its own, probably coming from yoga, would be helpful. But the additional benefit, I think, with the stress reduction through mindfulness training, probably has its own sort of additional benefit on top of just the physical activity.
Okay. So I think we have another question. So will an 85 years old with a sister with MCI be able to participate in research?
Yeah, definitely. So usually in our clinic, actually, it's the lower age range that we have a cutoff for. Most of our studies would enroll people, over the age of 55 or 60 or 65, and usually we wouldn't exclude someone just because of an older age.
Okay. Would dysphagia be MCI related? Dysphagia or aphasia, I guess?
Yeah, so it definitely could be. So if so, I'll just clarify. If you mean by dysphagia, you mean a language problem, then yes. So dysphagia usually refers to changes in language, and that could be it related to mild cognitive impairment. As I mentioned, even Alzheimer's disease has a language variant. And so some people may have, very good memory that's preserved, but they're starting to have changes in their speech. And that can be the first sign of a dementia developing or a neurodegenerative disease developing. And so, yes, people could have just a language problem and be considered to have mild cognitive impairment. So again, that would meet that criteria of having an impairment in one cognitive domain. And it could just be language. And then that person could be considered to have mild cognitive impairment. And I'll just remind everybody that, as I said, mild cognitive impairment is just a general term. All it means is problems with memory and thinking or language that are more than expected. What we need to then find out is what's the cause underneath that. But language changes definitely could be a sign of mild cognitive impairment.
Yeah, so there's a question here. Could you comment on upcoming 2025 study regarding semaglutide and lower risk of Alzheimer's?
Yeah, so we don't have the results for that. So semaglutide, also known as Ozempic, as I mentioned, when I showed that, and one of the reasons I showed how complex dementia is because we are realizing that although those amyloid plaques and tau tangles are really like the hallmark of Alzheimer's disease, that's not the only change that's happening in the brain. And so things like imbalance in blood glucose metabolism and how well the brain is processing blood glucose or using sugars is a factor. So things that improve diabetes control, blood glucose control could help. So, I can't comment more to say that the study results, I believe, are expected later this year or early 2026 at the latest, but they have a larger, what we call phase 3 trial, meaning a trial where we could get more idea of if there's a benefit or not using the Ozempic. So, in my mind, it's very promising that we're looking at different aspects of what could be the cause of mild cognitive impairment and dementia. Because as I said before, I think, these new medications, they're a huge step forward. Having a disease modifying medication for Alzheimer's is really exciting. And it's hopefully going to drive more research as well and give some benefit to people with these medications. But it's not going to be the only thing that cures it, right? As we saw with those, lecanemab and donanemab, they slowed things down, but it's not like they stopped it or reversed it, right? So we're probably going to need, multiple different types of treatments that are going to work together. And semaglutide or Ozempic has showed some promising results in early studies. So hopefully it'll be another thing that shows a benefit in some people.
Okay, another comment here. Where can I obtain the MSS planner?
Right. So yeah, just reading that. So the MSS planner of itself is it really needs to be done. And the reason we're doing this study is it really needs to be done with the training. So that, it's a 10 session training to learn how to use this. What they found with that is if they just give the person the planner, even though the planner, is a bit more organized than other types of day books and things like that, without the training behind it, people don't get to know how to use the MSS planner, and it's not they aren't getting the benefit from that, because what you need to do is really train that procedural memory, that habit memory on how to use the planner. And so an essential component of that is doing the training with it. So right now the MSS planner is only available at the Mayo Clinic through the Mayo Clinic store. But I would say that, just buying that on its own isn't going to show the benefit of what we saw in those studies where I showed, the MSS planner did help people, but it was part of that training program. And so we, as I said, we are testing that here to say, and we do have a cohort of people enrolling who go through that training. The other thing that I see, I guess this is reference to someone that I saw as well. But so, yeah, there is a difference between mild stage dementia and mild cognitive impairment. So maybe I'll just go back. So mild cognitive impairment is a step sort of before dementia. So mild stage dementia is when people are just starting to have changes in their day-to-day activities. So there is a distinction. And I know some things are hard because, we use the word mild for so many things. But a mild or early stage of dementia is once someone has already started to have problems with their daily activities. So it would be different from mild cognitive impairment. It would mean that person has progressed from mild cognitive impairment to a mild dementia, meaning some of their day-to-day activities are declining and they're having more difficulty there. So there is a difference between mild cognitive impairment and mild dementia. Yeah, and then figuring out the reason for decline is always hard. A change in environment can be difficult for people with dementia. They're very good in routine. Sometimes that's needed though, because sometimes there's additional benefits, right? If someone was on their own and having some difficulty with day-to-day activities, moving into a supported living environment might give them a reduced stress. They don't have to worry about things that they're struggling with, like cooking or cleaning tasks, taking medications, and then sometimes it increases the chance for socialization. So we want to work, and some of the research we're doing is to work to support people to age in the place of their choosing. And for some people that's their home setting with additional supports, but other people moving to assisted living or a communal living like a retirement home can be helpful and beneficial too.
Okay, so there's a comment here. What is the next training session schedule?
So that's not a question I can answer. What training are you? If you're referring, I don't know if that's for this session here for MCI or the mile or the MSS training sessions. If you're referring to the research study, that we're continuing to enroll. So we're enrolling people continuously for that, probably for the rest of the year. So that would be at any time, and we work with the person's schedule. So for the first step with any research study is connecting with our group and seeing if you qualify. So there are often inclusion and exclusion criteria. So people have to meet certain criteria. Like for some studies, obviously you have to have a diagnosis of just mild cognitive impairment, but there may be other things. And so connecting with our research team, you can ask them and find out about different studies that are enrolling right now. And then our research assistants and research coordinators will work with the person interested in research to get them started on the study if they qualify for it, and then work with their schedule.
All right. Okay, well, maybe I have also a question that we receive often. So what is a biomarker, Dr. Thomas?
Yeah, okay. So a biomarker is just it's just a test that we can do on the body that is a marker, or it gives us an idea, or a test that tells us about a disease. So just really, I guess the longer version would be a biological marker of disease. And a biomarker can be multiple different things, as I showed. It can be we can get a biomarker from a blood test. So again, we can look for high cholesterol. That would be a biomarker. It could be a test like checking your blood pressure. So high blood pressure could be a biomarker. It could be a test like a brain scan. So again, the amyloid PETs are looking for that biomarker. Or even looking at digital biomarkers. So, measuring your sleep or your daily activities using a Fitbit watch or a bed mat, things like that. There could be, digital biological markers of disease and changes that might be happening in your sleep or daily activity that predict cognitive impairment and dementia.
All right.
Yeah. Oh, so there's just a few. So yeah, the training for the MSS planner, as I said, those trainings are done one-on-one with a research assistant. So the first thing right now, we're not offering it as a clinical program. We're hoping to move towards that, but the first step is to get some evidence and evidence from a research study to be able to kind of explain that it will be a benefit, and then find funding that we could offer it as a clinical program. So the next training session, there's no fixed schedule right now. Again, that is all just when one person enrolls, they would start the training with our research assistant. So we don't have a running clinical schedule for it right now. It's really just an individual basis if someone enrolls in the research study. Yeah, and to learn more about any of that, you can contact the number here or email memoryresearch@bruyere.org.
Okay, perfect. So, well, it's 6:06. So just a reminder, don't worry, you don't have to memorize all this. This has been recorded and you're going to receive an on-demand video so you can watch it again. And in addition, we're going to share all the information about the research happening at Bruyère Memory Program. So again, everyone, thank you for joining us today. In addition, we're coming back with a lot of education in June. So if you're interested to keep following the content on MCR or dementia, we also have Dementia Basics coming up next month, and it's going to be in person and online as well.
Yeah.
So with that, you have any comment, Neil?
No, I did also want to say that later this year, we will have new drug trials starting at the clinic as well. So again, another reason to contact our team if you have any interest in any of the studies that I've talked about today, but also testing new medications like those donanemab and lecanemab. So there's new drugs that are being tested and will be part of some of the studies.
All right. So, well, it has been a great pleasure to be your host today, and I also invite you to keep coming to our webinars coming up in June and July. We have a lot going on, and thank you again for joining. Thank you to our volunteer, and have a great evening, everyone. Stay well.